Perfect. Okay. So we'll start off with the case presentation. We'll stop along the way for some opportunities to discuss like the case and some of the main issues. So our case starts with a 76-year-old male who presented to the ED after a visit at his geriatrics PCP, where he was noted to have failure to thrive, unintentional weight loss, and highlighted here with current BMI of 17.7, as well as fatigue and a lack of appetite. I'm going to jump now to the past medical history because it is pretty extensive and will help you guys know a little bit more about the case. So as you can see, the patient has had a very complex medical history, most notably diabetes, non-ischemic cardiomyopathy with HFrEF and EF of 35%. As you guys can see, multiple malignancies. So we have Hodgkin's lymphoma, gastric cancer, thyroid cancer, lung cancer, bladder cancer, ITP, and previously on infusions with a CSF stimulating factor with a platelet baseline of around 40,000. Chronic hyponatremia between range of 130 to 134 that was suspected to be consistent with SIADH in the past. And he had a recent prolonged admission for bacteremia with discitis and a left psoas muscle abscess that lasted for about 6 weeks in the hospital and was complicated by new heart failure with reduced CF, as I mentioned, prolonged course of antibiotics, and significant deconditioning where he was discharged to subacute rehab and then discharged back home. Of note, during that admission, he was also found to be COVID positive, but he never developed COVID symptoms and did not require COVID treatment. So again, so this is with all of these medical issues, he came to his PCP's visit and was noted to have significant failure to thrive with the weight loss. So at this point, we'll just take a moment and maybe have some of you guys weigh in on what information would you like to know now that you're seeing this patient in the hospital, before deciding how to manage this case.
This is our time to shine, guys. You can either unmute yourselves or write it in the chat. So we have a pretty complex history here. Should we start with review of systems? What things would you like to ask this patient? So let me see if I can summarize. An older adult coming with fatigue, unintentional weight loss, multiple comorbidities. Most importantly, I guess, cardiovascular disease. We mentioned heart failure, multiple oncologic processes, ITP, and recent hospitalization for an infection. There we go. So Bruno would like to ask what matters most to the patient, what the code status is. That's a good way to make use of the previous lectures. What are the current medications for this patient?
Okay, great. Anybody, so current medication, compliance with medication, great. So the patient is coming from home but was previously in subacute rehab. We will discuss, there's some questions about cognitive baseline, great, and functional, functional baseline, fever, chills, so systemic symptoms, constitutional symptoms, baseline mental status, great. Anything else specifically? Great, functional status. Anything specifically about specific review system given the failure to thrive? So living situation, goals of care, great.
Raj is asking, is weight loss associated with abdominal symptoms, nausea, vomiting?
Great, tolerating PO, great. Change in appetite, great. Okay, so we'll stop there. So all of those are great. We'll go over that, so that's fantastic. Just before we go over into all the things that are important to know about the case, like take the opportunity to ask Dr. Rughwani, just kind of like, given this complexity already, I guess a good opportunity is, when would you refer a patient for failure to thrive to the ED evaluation? Let's say instead of, doing additional workup in the clinic, outpatient.
Thank you. I think all of you brought up some incredible points. Thinking about what is the current situation? Why is this weight loss? Is this something that could have been prevented? Is this something to do with how this patient is living at home? Do they have enough support? Are they getting the food that they need? Are they eating the food that they need? How much of this can, for me, always I have a few things that I look at. First thing I look at is, how stable is this person, right? Can I feel like I can send this person home and feel that I'll be able to manage whatever they have outside of the hospital, and yet they'd still be safe? So that's the first thing. Are they going to decompensate if I'm sending them home? My second thing is, well, if this is someone who really isn't able to cope at home, are we sending them back to a situation at home where they're not going to be able to cope and they're going to continue to fail to thrive? This patient was recently in the hospital, which makes you think they went home, they were discharged as something, obviously not, that's an important history, because could that, whatever, they were here for the discitis, could this be worsening? Is this something that they can manage? So here with this patient, the way it is, I'd probably say, given the multiple comorbidities, given recent hospitalization, recent transfer of institutions, right? Went from hospital to subacute to home, something could have be missed there. How do we get this patient back and forth? So some of the answers to your questions that you all did great with are important and really help guide my decision for being admitted to the ER or not.
Yeah, thank you so much, Dr. Rughwani. I think those are kind of like the key things. And I think it's an important thing to know when to refer patients to the ED, because I'm sure all of us have seen patients and see frequently patients with failure to thrive. I mean, depending on obviously which specialty you are, but it's definitely in internal medicine. And it's a question of, when do we refer patients for expedited ED workup or hospital workup versus outpatient workup? So those are great points. So going further to the patients, to give a little bit of information and to answer some of the questions you guys were asking. So basically, it looks like the patient's symptoms have really worsened in the last month. Basically, every time he eats, he has been having a multitude of symptoms, including lower and upper GI symptoms. Also feeling like some food is coming up, and one episode of vomiting, loose stools, possible indigestion. He has lost 20 pounds in the last few months. And also, in addition to that, he has been feeling more depressed, all in the setting of a decreased functional status, as well as a recent fall that he experienced in the SAR before being discharged home. And also, his depression has been worsened while he was in the subacute rehab because of not being able to see his son frequently due to visitation, policies. In terms of the negative review of systems, so he didn't have any melena, no kind of bloody emesis, no abdominal pain, no fever, no headache, or urinary symptoms, no constipation. In terms of outpatient medications, I'm not going to go through all of them, but as you guys can see, he had a multitude of medications, so not that many for diabetes, although he did have a sulfonylurea that he was on for his diabetes. Multiple medications for depression, so bupropion, quetiapine, as well as he did have some pain medication with morphine that was for his discitis that was started after his bacteremia hospitalization, but he wasn't really using the morphine that frequently. And I think I will leave it at that with the medications. In terms of his baseline mental status, so he was cognitively intact, but as I mentioned, feeling more depressed in the setting of this prolonged prior hospitalization and all the issues with subacute rehab in the fall. In terms of his functional assessment, so he previously did not require assistant device for ambulation in the past, but now he, since the bacteremia hospitalization, he has required a rolling walker. Previously, he was independent, did outpatient physical therapy, had some meals on wheels, but was able to take care of himself. And basically now not able to take care of himself at home, cannot get around, had a fall in SAR, as I mentioned, more depressed. He has been getting assistance from social work for expedited homemade referral, but this can take time. And it's been difficult for his son to stay with the patient, and no one else can take care of him, basically. He lives alone, has a dog that he's not able to take care of anymore, has some only assistance for housekeeping, and also some assistance from the son. In terms of his healthcare proxy, so his son has been appointed as the healthcare proxy on prior admissions. He's full code. Most important thing that we gathered from his prior hospitalization is that he really valued independence and really wanted to be able to return to a independent functional status and being able to take care of his dog. He had some history. He's been married twice, has 2 sons, but only close to one of them, no alcohol. So initially the workup, when he was presented, he was his blood pressure was on the low side. Otherwise, you can see his vitals were stable. His weight, again, I'm highlighting here that his BMI was 17.7. And as again, I mentioned, he lost 20 pounds in the last couple of months. On exam, main thing to note is that he was very, very thin and chronically ill appearing and had notable low muscle mass that was symmetric. He seemed a little low in his mood given all the circumstances, but he seemed euthymic otherwise, and was like hoping to, the medical team and the geriatric team to get to the, to help figure out what was going on. These are the labs, the pertinent labs in the ED initially a workup. I'll just draw your attention to the thrombocytopenia, which seemed to be at his baseline given his ITP. He had an elevated BNP, which was above his baseline. His albumin was a little low, 3.3. He did have, as I mentioned, some electrolyte abnormalities, including the hyponatremia, which seemed to be close to his baseline, but he also had low potassium, a little bit of AKI from his baseline, some transaminitis as well, as you can see here. He had an EKG that showed AFib with RVR with a rate of about 110. And I would say that in the past, his prior EKG were they were kind of inconclusive whether this AFib was new or not. So I will leave it at there. He had a CT abdomen and pelvis given all his symptoms that basically did not show any worsening of the discitis. He had some notable dilation of the, extrahepatobiliary bile duct that apparently was present in the past. And he had a resolution of his prior iliopsoas muscle. So I think hopefully now you guys can see a good picture kind of like of this patient's state on arrival to the ED. So I want to take this opportunity now to maybe talk a little bit about frailty and failure to thrive. So probably most of us have heard the term frailty, but I just want to, Dr. Rughwani, if maybe you could talk a little bit about frailty and how we actually define it and what are the components for that.
Absolutely. So it's interesting, frailty is very common, and we see that as people get older, And how do we say someone is frail? So some of the things that we think about is functional status. That's very important, and how many of their ADLs and IADLs can one do? Slow walking is thought to be one of them. And I actually have a very nice slide that I wanted to pull up, but I needed to find it, and for some reason it has disappeared off my screen. But so you want to look at functional status. Weight loss is another one that we look at to say, okay, well, how much weight have they lost if they've had a significant weight loss, if they have significant low BMI, slow walking. Oh gosh, the other ones, I have them on a slide right now. I'm going to have you talk for a minute, Dr. Gorenstein, while I find the slide, if that's okay.
I believe we're talking about weight loss, exhaustion, weakness, slow walking speed, and decreased physical activity.
That's it. Yep. Mm-hmm.
Yeah.
And there's a nice, and you need 2 out of, hold on, I'm going to show this to you guys in a second. Sorry, I'm going to let you continue talking because I don't want to take away from your time. And I'm going to talk about it in a minute because I just presented this recently. And it kind of defines it nicely when I get there. Give me a second.
Sure.
And we actually use a lot of, go ahead.
I was just going to say, I think the key is also now, hopefully everybody can see that this was, I think, a good legitimate reason to refer this patient to the ED, given his prior, as Dr. Rughwani mentioned, like his prior prolonged hospitalization and this whole illness with the bacteremia. So he had a lot of things where I think both in terms of his medical issues, but also in terms of his social situation and his debility at home, that kind of would make it difficult to really try to figure things out outpatient. I think frailty is important because basically, as you already heard, we have from other lectures, geriatric patients in general are just more predisposed for developing disability and deconditioning. And I was just going to say that frailty, and it's when you add frailty into that, with a geriatric patient, I think it's something to keep in mind because it also increases the risk of further developing worsening debility and deconditioning, but also recovering from from their debility.
Right. So there are really 5 criteria. And I find my slides. So if I share though, Dr. Gorenstein's slide will disappear, but I can do that in a minute. Yes. Okay. So I'm going to show you a slide that actually talks at frailty and look mortality. Can you all see that now?
We can.
Can everyone see that? Okay, so there's 5 criteria here: weight loss, weakness, exhaustion, slow walk, and low activity. And you need 3 or more of these to really be defined as frail. And if you look at this graph, you can see that, so the solid line is someone with not frail at all, intermediate frailty, and people who are fully, who fulfill this criteria of 3 or more. And as people get more frail, their mortality risk increases. So that's the important takeaway here, is that it's important to recognize and to actually seek out people to say, okay, they are frail, so they already have an increased mortality risk, and this is one of their risk factors. Okay, I'm going to let you go back to your slide, Dr. Gorenstein, sorry.
Yeah. And we actually include this, I will just say, we actually include this frailty tool. We included in our initial visit geriatric template note. So, and actually after, in the past, when we have been discussing cases, it may be something worthwhile in the future of even involving it, I think, in inpatient template notes as well. Because I think for a lot of us, it's very easy to miss frailty. This case obviously is obvious, like it's easy not to miss it. And sometimes you'll see patients that you can just tell they're frail without even like doing all the assessment. But a lot of the times, the community dwelling adults and both outpatient and when they get hospitalized frailty is sometimes very subtle, and I think it's something that important, again, to recognize. The second question is about the failure to thrive. That's obviously the key kind of problem in this case. Dr. Rughwani, just wondering, how would you, like, with giving this ED workup, what are kind of concerns would you have initially about like failure to thrive, and how would you generally approach a patient like this? And
so I think this patient has multiple things, right? I think the multi-morbidity is a huge one. In and out of hospitals, so multiple hospitalizations is one other kind of thing that you look at to think, oh, is this person thriving? Weight loss is a very good indicator of someone who's failing. This kind of functional decline that this gentleman has had, where before he was independent, now he needs a rolling walker, he had a fall, he's not able to do the things that he wanted to do, right? He's now not independent anymore in his ADLs and IDLs. He needs help. And so this is an indicator that he is not thriving like he should. And that he's starting to fail to thrive. He's got multiple medications, which makes it always challenging. And we're going to talk about multiple medications later. But that's another thing to think about, right? As people start to fail, one ailment leads to another ailment, leads to another, to medications. And it all is just this cycle that kind of snowballs. But those are some of the indicators that I'd look at. And he's really not able to thrive at home in the situation that he's living in currently, which is why he's in the hospital and in the ED being worked up. And that's important to think about as you think about the course of this patient and what happens to them.
Yeah. And actually, I think maybe it's some opportunity for some of you guys to say, now that you've seen this patient, imagine yourself, you're seeing this patient in the emergency department with this initial workup. When thinking about causes for his failure to thrive, what are some of the things that jump in your head? If you can share on the chat. What I mean is that what are some of the causes that you think are contributing? Dysphagia, okay. Depression, general aging. So depression, poor social support. What about health? What about body systems? Which kind of infection or C. diff? Okay. What about in terms of his past medical history? GI system. Okay, great. What else? Malignancy, right? So he's got history of 5 cancers. So that's really important to keep in mind. What else? So we have, so there's a couple of, so dementia is not in this case, because he is cognitively intact. What kind of things are you guys thinking? Somebody, Darren, you mentioned GI systems. So what kind of things are coming to your mind apart from gastric cancer when you're thinking GI system? So SBO, colon cancer, diverticulitis. Okay, gastroparesis. Okay. Great. Thank you. And thank you, Raj. Yeah, so those are great. I think the one, so you guys have hit on the major, like a lot of really important kind of things that could be contributing to the failure to thrive. I think one other thing I will just add is that he does have a new diagnosis of heart failure with reduced EF, and looks like he has new atrial fibrillation. So I will, even though he's, even though overall his vitals he's not in rapid rate, but that could be, that's the other thing. I would also add, so Raj, you mentioned pancreatic insufficiency, so I will just add other things like celiac disease or just other type of malabsorption syndromes for that, and medications, as Dr. Rughwani mentioned, and also like the fact that he had such a prolonged hospitalization in itself, the deconditioning can have a large impact on someone failure to thrive. I will just say, so maybe Dr. Rughwani, I think one thing that before we jump further to help clarify, what would you consider, because I think it is important to us to identify when we see failure to thrive, how do you define whether it's, or what do you use to decide whether the failure to thrive is more to just, let's say, age-related process versus, let's say, you know, an organic cause? What are some of the, I guess, red flags that kind of you think of? Okay, I think we'll just go to.
Nisha, I think we can hear you. I think maybe Dr.
Okay, okay.
Rughwani's having some issues with her connection.
No problem. We can get back to that later because I think it's a good I think it's a good question whether to know whether the failure to thrive is because of general aging versus whether it's due to, like, you know, like an organic cause or an acute, like, medical issue. So maybe we can talk about it later. But I think the key here is that this happened pretty, I would say, subacutely, right? Because it had been going on for about 2 months. It's not something that's been going gradually. His memory is still intact, and he had all these other, you know, additional GI symptoms, which would make you think that, you know, that it's more to do with, that it's more to do due to some sort of illness rather than aging in itself. So just jumping off into the inpatient course, to give you guys some overview of what happened during the admission. So he did have, as you guys mentioned, you were worried about GI symptoms. He was seen by GI, had a colonoscopy and an EGD. On the EGD, he was found to have a hiatal hernia, esophagitis, and gastritis. And gastritis was confirmed also on the biopsy, but negative for H. pylori. He had a colonoscopy that was positive for tubular adenoma, so it was possible that gastritis was contributing to this patient's symptoms. So he was started on PPI, simethicone, probiotic, multivitamin. He was also followed by nutrition for severe malnutrition. He was evaluated by cardiology because of his, you know, because of his known cardiac issues and heart and HFrEF. He had a repeat echo that showed worsening EF of 21%. It was believed to be due to atrial fibrillation. So after he underwent his GI workup, he was started on Eliquis, then remained in AFib remained with AFib that was intermittently going into RVR. So he underwent TEE, so transesophageal echo with cardioversion. And then his cardiologist thought that maybe he could do a nuclear stress test as outpatient to rule out ischemia. Given his multiple malignancies, the teams corresponded with his outpatient oncologist, basically really to know whether he needs infusions for his ITP with the romiplostim, which he did not. He did require platelet transfusion prior to the EGD. Given his failure to thrive, and also of note, he had one of his biomarkers, CEA, was elevated in outpatient setting. That his oncologist wanted to do a PET scan, but because of the patient's poor functional status, they anticipated a poor prognosis. He had multitude of other issues during the, sorry, just one moment. He had a multitude of other issues, that added further to his complex admission. Things like having a loose tooth crown, which required further evaluation by oral maxillofacial surgery, nutrition, as I mentioned, and his PO intake fluctuated throughout his admission. He developed a UTI. And then when his clinical status kind of became a little closer to more stable, and when we started to consider discharge for subacute rehab, he developed significantly worsening depression with suicidal ideation and declining treatment, basically saying things like he tried to hold his breath, expressing desire to seize and deceased, requesting injection to help him die, no longer wanting to be a burden for the family. And during all this time, he developed even worsening decondition and basically not even being able to use a commode and basically being confined to the bed. So again, like I mentioned, a few months prior to that, he was fully independent. He's been placed on a multitude of medications, had a CT head that didn't show any acute abnormalities, and eventually transferred to psychiatry unit because of his severe depression. And then he was later discharged to subacute rehab. So I think like this case just kind of highlights a lot on the multi-complexity, as well as the polypharmacy that has been significantly increased throughout this hospitalization. If Dr. Rughwani is back, I think
I am.
Okay.
I'm so sorry. My internet connection was it's just been doing this all day, but now I'm on my phone in a different area. So I'm not going to have my video on just in case that breaks it up again. Absolutely. I think, people having multiple medications is a huge problem, because you have, firstly, it's the burden of the pills, right? Patients don't really want to take lots and lots and lots of different medications. It is a burden. It gets them, it's challenging to do. The second thing is also, when you have so many medications, there's a lot of high chance that, there is a lot of interaction between medications, so that you can actually, different medications interact with each other, and that can cause problems. And just having so many different medical issues in itself can cause significant kind of pressure on patients, and mortality and morbidity. And studies have shown that patients who are on multiple medications and who have multiple chronic conditions, it kind of increases their morbidity and mortality as a result.
Yeah, I think that definitely. And given this patient's inpatient course, where he basically was seen by so many different specialties, is there any kind of thing, if you started off with this case at the beginning, because I think it was challenging for everybody really to know what to address first before the patient developed depression. Is there any kind of different approach in terms of what you would focus on first, given he has GI issues, cardiac issues, nutritional issues, as well as known depression? Is there a different approach that you would have given this multi-complexity throughout the admission?
I mean, I think one of the biggest issues always happens, and whether it's during admission inpatient or whether it's outpatient, a lot of what ends up happening is that the different specialties need to talk to each other. They need to come up with a plan, and you need someone who's going to kind of coordinate that plan, right? So whether it's a geriatrician, primary care physician, internist, trying to figure out, when everyone has their pieces, a lot of times the different specialties are working, but not congruently together, right? So everyone's doing a different thing. And then I think the big thing that someone had mentioned earlier is kind of what matters most. What does this patient want? How do we address these issues and talk about the best plan for this particular patient? And I do frequently, actually, sometimes we have, now that everything's Zoom, when I'm not having connectivity issues, we have a lot of times where we actually do, we'll Zoom sometimes with the patient or without the patient, depending, with some of the other specialties, to try and talk about the patient, almost like a case conference, or a family meeting or something where everyone on board and every specialty can kind of talk to each other and know what's best for this patient. So this is, it's hard to say what do you treat first, because the patient does have these multiple issues. It's always kind of, what do you treat most, for several reasons. What is what's going to affect their stability, morbidity? And then the second thing is, what can you, if you don't treat it, how sick are they going to get? And the second thing is, are you treating that to make that patient better, ameliorate their symptoms? And are you working congruently with their wishes and their goals?
Yeah, and I think really the hard part was kind of with the patient also asking, because he was seen by his cardiologist, his outpatient cardiologist was seeing him inpatient and coordinating all the cardiology related procedures. We were corresponding with oncology from his outpatient oncology clinic. And on top of that, I mean, he also had all these GI issues. I think that's definitely highlights kind of how important it was to discuss all these things together. And this is before he developed severe depression, where he wasn't able to really make informed decisions on his own. And I think this also, just wanted to highlight again, the multi-complexity when you have somebody with failure to thrive, multitude of symptoms, where you have to consider different body systems instead of just, let's say, one, like let's say just the GI tract, which you probably also heard in other lectures as well. I think in this case also, now that we kind of seen how complex this patient's hospitalization was, when we are getting ready for discharging patients, and some of you have already done this if you've done geriatric inpatient rotation already, that a large component of geriatrics is transition of care. So transition when patients are being transferred from, let's say, hospitalization to a different setting like home or subacute rehab. I think it's useful always for all of us to know kind of what are the steps, as well as what are the hazards of readmission, which were again highlighted by some of the talks earlier. Dr. Rughwani, I'm just wondering if maybe if we could talk a little bit about some of the steps that we include before we discharge patients, such complicated patients, and also just some of the maybe things that we keep in mind about the hazards of readmission.
Absolutely. Transition's a big thing that we work on, because it is critical. Things happen in the hospital. We stop medication, we start medication. We do different tests in the hospital. All these things, when people come into hospital, when they leave, they're different to what they were when they came in, right? Things have happened. So what's really important is trying to communicate with the primary team, their outpatient, who is their geriatrician, who is their internist. Let them know what was done in the hospital. Which medicines did you start? Which medicines did you stop? What do you need to follow up on as you are discharged? So, if you said, okay, this patient did a CT and, we're not sure they need an MRI, but we're going to send them home and let's do that post hospitalization. Well, let the internist know that, or the geriatrician know that, so that they can follow up on that. What services were implemented into the home? What was, did you refer to VNS? Did you refer to a home health aid agency? Did you talk about goals of care in the hospital? And if you did, what was the conclusion of those goals of care? What was decided upon? All of the things, and again, it doesn't have to be a very long essay. In fact, that is more challenging. And we have a template that we can share with you that we do discharge summaries, which are very simple, a brief summary of what the patient was in for, brief things of tests that were done, what medicines were stopped and started, their complete medical list, and then who should they be following up with, or what tests or results. Someone had a pathology done, the results weren't ready. Someone needs to follow up on that. And how do you manage that? How do you do that? So all of those things I think are really important to have that. And it's really important for that patient to be seen and followed up in clinic. Because a lot of times, I don't know, and I encourage you to, when a nurse discharges a patient, I highly encourage you to just witness what that looks like. They give them a bunch of papers, like 12, 14, like lots and lots of them. And they just give them to patient, they kind of briefly go through it, and that's it. So the patient goes home. Quite a significant number of the time, that patient has not read that or doesn't really understand what changes were made. They go back to taking their old meds and they're back in the hospital again, or whatever it may be. So, you know, trying to have a very close visit in the outpatient practice is really important. And one of the things we do in our practice, in our geriatric practices, anyone who's like discharged, who's discharged inpatient, we get the discharge summary, and our nurse actually makes a phone call to say, just checking in, how are you doing? What are the medications you're taking? You know, BNS was supposed to come to your house. Did the nurse come? Did physical therapy get started? So that phone call is made usually within 2 days, 48 hours. And Medicare actually compensates you for this because they think it's so important. So you check in with a phone call. Once you're done with the phone call, we like to see the patient within 7 to 14 days. And again, that visit is purely a post-discharge visit to follow up on everything that happened in the hospital and to make sure that patient understood what happened and has transitioned back well into their home. So, you know, it is critical. And when you look at the studies, a lot of rehospitalizations are actually secondary to patients not really understanding what happened in the hospital, and a lot of what recommendations were made just doesn't happen and doesn't go through. So those are the important, you know, I cannot stress the importance of transitions of care and effective transitions of care.
Yeah, and thank you so much, Dr. Rughwani. I think also looking at the after visit summary when you discharge patients, it's really important because it can get, the key thing is that I think if you look at it carefully, it's very, very confusing, even, you know, for anyone really to go through, especially when it has a whole multitude of things on it. So I think one thing I will just say, make sure when you are discharging your geriatric patients, you preview your after visit summary before the patient gets discharged, because a lot of things can, whether it's an incorrect medication dose or anything, can get lost in such complex cases, and it's really important to review it before. Just a quick, 45-second questionnaire for everyone. What are some things you guys are worried about this case now that this patient is being discharged into subacute rehab after such illness? What are you worried about in terms of risk for readmission? You can type it in the chat. So safe discharge, medical adherence. What are the things that you guys are worried about for risks of hospitalization again? Psychiatry follow-up, yeah, that's really important. Falls. What about anything specifically for his multitude of medical conditions? What are you worried about? Okay. And follow-ups, yes, lots of follow-ups. Ability to pick up medications, right? Any medical conditions that you guys are worried about? Either the new conditions or the old medical conditions that you're worried about? Atrial fibrillation, worsening HFrEF. What about this? What about all these malignancies? Yeah. So yeah, progression, exactly. Yes, Venus. Yeah, exactly. So it's so confusing, right? Like, so he's got so many complex issues. So those are all definitely things that we would keep in mind when discharging this patient, whether we can address all of those safely. So next thing is just an outpatient course, brief outline. So patient was actually recently seen in the clinic 2 weeks ago. He left subacute rehab early, and he has gained some weight. So his BMI is back to normal now. It's still on the low side, but it's at least at 20. Still has some back pain, doing home physical therapy. As you guys have mentioned, adherence to medication. He stopped his PPI, then resumed it again because of potential side effects. He saw gastroenterology, was also found to have pancreatic insufficiency, started on pancreas lipase, but again, issues with adherence. Saw cardiology, and looks like his HFrEF has improved, so they think it's likely due to the atrial fibrillation. They didn't want to do any additional ischemic workup at this point. He saw oncology. They adjusted his Eliquis dose because of his low weight. And his platelets remain kind of at the baseline, but very low. Still no PET scan. He hasn't had an outpatient PET scan, which was at some point planned. But the most important thing is he saw pulmonology a few weeks ago, underwent bronchoscopy with 2 biopsies, one of which was positive for adenocarcinoma, consistent with disease recurrence. In terms of psychiatry, also an issue because of his some insurance issues, he hasn't been able to establish outpatient psychiatry follow-up, and social work is assisting with coordination and referral to a different psychiatry department. Not going to go through all the medication, but as you guys can see, his medication has basically became more complex. So he's also, I will just say here, he's on a diuretic now. He's on multiple medications for his mood: mirtazapine, buspirone, citalopram, trazodone, Seroquel, and then he's on all these. He's on anticoagulation now, as well as all the GI-related medication. Still doesn't have a home attendant. Son is helping, but there's a lot of caregiver burden. And there's ongoing issues as the patient's still not able to take care of himself on his own. For instance, like, having accidents at home when cooking. So I think we're going to finish off on the one thing is coordination of care. So with that, just to distinguish it from transition of care. So this is like about, when we're actually seeing such complex patients in the clinic, as I think we already discussed, there's a lot of coordination with different specialties, social work, and other departments that we do. I think the key thing here is maybe Dr. Rughwani in this case is, when do you think is a good time to discuss goals of care? We couldn't do it. It wasn't possible during the patient's last part of hospitalization because he developed severe depression and didn't have real insight into all his conditions. But it seemed like it's better under control now in the outpatient setting. And now he's got a new diagnosis of disease recurrence with his lung biopsy. So I guess, yeah, at which point would we do goals of care, and what tools would we use to help with the prognostication?
Absolutely. I think this is actually, you're right. I think it's important to have these goals of care discussion when you have information. So we're asking patients about what it is that they want. And if they don't have, it's that whole informed decision. It's not only about what you tell them and how much they understand. It actually is a little bit also about the information that you have that's most recent and most valid. So given that you have a new diagnosis that will definitely affect his morbidity and mortality, I don't think that this is a bad time. The depression, he's on medication, but he still is not seeing psych. There is that significant, back to your coordination of care, there is significant caregiver burden here. There are lots of issues that have not been settled. I think this is a good time to talk to him about kind of what's important to him, what matters to him. Again, there's some great slides that will show you that functional decline is also related to increased mortality, and is actually an independent risk factor too. So if he's going to decline and function more, it goes back to the whole, what matters most to him? How do you assess someone's mortality, right? How do you tell someone 5 years, 10 years? Sometimes it's part of staging, but a lot of times it's actually their chronic medical conditions And there's a very good tool online called ePrognostic. I'll send you guys this. I'll send it to Dr. Gorenstein, where you can actually plug in information, right? This gentleman has had multiple malignancies, CHF, you know, he has AFib, he's anticoagulated, he has a lot of multiple comorbidities. And the more comorbidities someone has, that increases their mortality. And so keeping all that in mind, so it's kind of, what are their medical conditions? What are their, prognosis, what are their medical conditions? What are their goals? And where do they want to be, right? Functionally, where do they want to be? What does their life look like that is acceptable to them? And that's very important too, right? Some people may say, you know, I don't want to have chemo and radiation again if it means that my life expectancy is not going to change. So I like this tool usually to say kind of, you know, what are the comorbid conditions? And this gives you a good estimation roughly of how long that person has. And that helps, I find, guide the decision a little bit better. But I think a big takeaway for me always when I do these talks is really know what is important to the patient. And we know from before the hospitalization that the patient's goal was to be independent and take care of his dog, right? So are we going to achieve that? And if that's unachievable, then what's the best thing that we're offering him that he can, and is that acceptable to him? And the oncologist weighing in here is really important because it also depends on kind of the treatment options that the patient has and the success rate of all of those and the burden of treatment that comes with it. This is a man who's had multiple malignancies, so he knows what the treatment burden looks like. You put that in together with decreased functional status, and that kind of helps paint the picture a little better for the patient as to how much they want.
Yeah, and I just, hopefully you guys could see while we were, you guys could see my screen as I was filling it in. And I think you guys can see there are multiple calculators that you can use depending on which setting you are, clinic or hospital. The hardest thing here is, like, you guys can see that it's very hard to prognosticate even for yourself, right? Like, we don't know really. He's got so many complexities, but but now he's got this new lung cancer recurrence. It's hard to really prognosticate even for clinicians, for us as clinicians, in terms of survival days, but it will change. Like, you know, it could be 100 days, it could be 50 days. It really kind of, it's not easy. And this is just an estimated tool, but it's definitely useful in this kind of case.
And in this case, the PET is still missing. So you don't even know if this recurrence is local or metastasized. And that also affects a lot of things, right? So it affects treatment plans, it affects mortality, morbidity, what you're prognosticating as well.
Yeah. I don't know if we have a minute or so for any questions, but is there any questions that you guys have about this case in particular, or just in general? I think I will just, we can finish it in that case, you know, we can finish it with some of the take-home points. I think this case, first of all, brings in like all the points earlier from today, discussing about deconditioning and prolonged hospitalization, incorporating frailty and functional disability into prognostication, and also when you guys are evaluating patients, thinking multifactorially, whether it's causes for failure to thrive, whether there is a potential, whether if patients develop delirium, what are their reversible causes. Having a high index, I think this case highlights really well for worsening depression in the setting of a severe illness or prolonged hospitalization. And many of you have mentioned depression, that was something that you were concerned throughout this case. So that's good that you're already thinking along those lines, and also looking out for the hazards of readmission, and also the importance of interdisciplinary approach in the coordination of care, and talking about patient priorities. We didn't highlight it here, but I think at this point now with this new diagnosis of disease recurrence, it's certainly something that's very important to, to do as well.
Well, thank you so much.